Now I'm going to go off the shoulder and give you some information about the meniscus. I'll try to do some pearls, some updated information, especially about things like the roots of the meniscus, the ramp lesion, a lot of tears that we see with ACL tears, and some pitfalls as well. So we'll start basic by looking at these menisci with a bird's eye view sitting on top of the tibia, composed of fibrocartilage. The medial meniscus is more C-shaped and the lateral meniscus is more rounded, with our popliteus tendon coming through the back. And there are many things that these menisci do. They provide stability, they do load transmission and shock absorption, and there are all kinds of competing forces that can cause tears, including compression, shear, and distraction that create different kinds of tears. I love to use this diagram to talk about the tears from Dr. Rosa's articles in MR Clinics of North America from 2014. And they show these fibrocartilaginous structures with a lot of fibers going longitudinal that provide hoop stresses to the meniscus. And you see medial and lateral menisci. It shows our cruciate ligaments and then the roots, anteriorly and posterior, lateral and the medial menisci. And the one thing I noticed that it doesn't really show is how the ACL gets very close to the anterior horn and root of the lateral meniscus, and the fibers intertwine. But it just really does a great job of showing our tears when we talk about them. More often, our tears are medial than lateral. And if you have a tear of the medial meniscus, almost all of them involve the posterior horn, and they can then propagate into the anterior body portions. Whereas in the lateral meniscus, you can have tears anywhere, more often posterior horn, but a lot of them are in the body or the body and the anterior horn, and 16% are in the anterior horn. And this is a really hot topic right now, is anterior horn, lateral meniscus tears, and how we are undercalling them. So what I'd like to do is say when we miss a tear, the false negative tears, which are more common than 3 to 1. And this is a more common problem, and we'll focus on these challenging tears, including just where the zero is pointing, a very small radial tear in the bow tie. It shouldn't have that little intermediate signal in the middle. So that would be a radial tear coming from the free edge. Meniscocapsular lesions, including the ramp lesion that we'll talk about in the posterior horn of the medial meniscus, often seen with ACL tears. Peripheral tears, also ramp lesion and others. The tears of the root. And there's all sorts of now classifications of those, and those flap tears that are unstable and should probably be surgically fixed. And when I talk about our tears, I'm going to use the Isakos classification. There's no definite classification that we all should use, but it really explains it well. And it was formed when knee surgeons from different societies got together, and they used the initials of those societies to come with the Isakos classification for standard terminology and classification of meniscal pathology. And this diagram from Wadwa's article shows us some of those tears. Notice the longitudinal tear, often seen with trauma, that propagates along the hoop stresses and the fibers of the meniscus. And it usually goes perpendicular to the tibial plateau, so from top to bottom. And a lot of our peripheral tears, meniscocapsular separation, type tears will be these. Next, we have the horizontal tears. They split that meniscus into two, or they go to the superior inferior surface and they are usually degenerative. Then we have the radial tears, going from the free edge to the periphery. Like the longitudinal tear, they go from top to bottom, and they can split your meniscus into two. And we see these more in the older individuals, but they can cause all kinds of arthritis if they're there, especially if they go all the way through. Then we have two kinds of flap tears. One is the vertical flap that looks like a parrot beak from above, And that's quite unstable. It's like a radial longitudinal tear from the free edge. And then finally, this horizontal flap tear that comes off the meniscus. It's still attached, but it goes down one way or the other on the side of the knee and the tibia, up or down. And they can be very painful, and they need to be fixed too. So let's start with the more traumatic type, the vertical longitudinal. That goes when you look at your meniscus and cross-section from top to bottom. And you'll see it on your any kind of sequence, T1 weighting, proton density, T2 fat sat. Here we have something like that, and you can see the high signal. It's still in the meniscus. It's a peripheral vertical tear. It's not right at the meniscocapsular junction. So you want to kind of say where that's located. It's in the posterior horn of the medial meniscus there. And here's a diagram of what the vertical longitudinal tear represents through that meniscus and in cross-section in the triangle. Now, these are usually caused by trauma and compression force, and let's look at this one. You can follow this proton density non-fat sat image, very classic, just like I had just shown you in the posterior horn of the medial meniscus. Now let's look at a certain variation of that in the 16-year-old soccer player who has some locking. Locking means there's something obstructing the knee, and it's often a meniscal portion of the meniscus. It's in the notch or a body in the joint. So let's follow this medial meniscus periphery to the notch. It's looking good until we get here. The free edges are starting to get blunted. They're kind of small on the anterior and posterior horn, but they keep going towards the notch. These are pretty thin sections. That posterior horn looks pretty bad. It's so small. And then we go into the notch, and of course, that's part of that meniscus in the notch, and we all know what this is. This is a double PCL sign and a medial meniscal bucket handle tear. If we look on the coronal image, we see that notch portion of this bucket handle and the periphery that looks so small. And these are surgical, these bucket handle tears. And when you look at them from above, they look like a bucket with a handle. Here was one case, the case that I showed you, and they found this fragment in the notch. You can see it near the PCL here. And there it is again. So what did they do in this case? They actually resected it. It looks so clean after surgery. Now, some of our surgeons are actually trying to preserve the meniscus these days, and if we get a bucket handle, they actually sew it back if that fragment isn't too messed up and the meniscus itself looks pretty good. So there are various ways to treat these. And this is what it looks like. They can be like a bucket with a handle, or they can be broken bucket handles where it's not completely a ring. So you may see tears in the bucket handle besides the handle going off. And when you're going through in your sagittal plane, you'll see your bow tie. It may be shortened a little bit, and you'll see your two triangles, and then another bow tie when it goes into the notch. And of course, you'll have truncated meniscus with the mesial displacement of the other portion in the coronal plane, and the bucket with the handle in the axial view. I find these are sometimes helpful for tears like this, for a lot of the tears I'm going to talk about, to get the axial view. And there it is again in the coronal plane. Now let's start with some ACL tear pearls. A 15-year-old soccer player with an ACL tear. I all of a sudden start thinking of all the different kind of meniscal tears you might have with an ACL tear. So we're on the medial side. So there's one particular kind you see here. And this is not fat sat, so you might miss this one. What do we see on the posterior part of this medial meniscus? It should be dark. It should not have a high signal going down vertically in the back there. It's not in the meniscus. It's right at the meniscocapsular junction. But if we look at our fat sat sagittal, we see it. That should not be there. It should never have high signal right behind it. So that is a meniscocapsular separation. And notice the contusion right below it. Many times, a contusion in the posterior medial tibial plateau means it's overlying meniscal tear. And it's usually what this is, a ramp lesion. So these are a very hot topic right now. We don't want to miss them. A lot of us missed them in the past. So now that we know about them, we're not going to do that as much. And it can be a meniscocapsular separation, or it could be a vertical peripheral tear. And it can involve the little ligaments that keep your meniscus in place back there. And it's only called a ramp lesion when you also have an ACL tear. You can see these without an ACL tear, but don't say ramp lesion. And a lot of these people have it. 40% of your ACL reconstruction patients have it. So it's good if you can mention it beforehand because it's hard to see with the scope. They pull on the meniscus and see if it's more mobile to try to make that diagnosis. Then they have to go in a different portal to get to it. So that's sort of the findings. And it's interesting that you see it with ACL tear. They think it's because you pull on your semimembranosus tendon, and you also have anterior tibial translation, which really tears apart the posterior horn of the meniscus. And it should be repaired during ACL reconstruction. Otherwise, you get all kinds of complications after the reconstruction, eventual bucket handle tears, or unstable knee that they have to go back in and fix this. So I like this article by Taneja, which shows us all the components that we need to look at for the ramp lesion. We see the posterior horn of the medial meniscus. We have the meniscocapsular ligament going upward and the meniscotibial ligament going downward. And these all can play a role in these tears of the periphery of the posterior horn. And they've actually divided it into different types. I don't really think you have to memorize this, but I love these diagrams for showing me what types can be there. This is just that meniscocapsular ligament tear, and the meniscus is okay. Those could be hard to see on MR, and they aren't going to operate just on that. The second type is having a superior peripheral tear that doesn't go all the way through. And I've heard they don't usually operate on just that either. But they start operating when it's an inferior peripheral tear that's partial there. And they'll operate on everything else I'm showing you. Sometimes that peripheral tear can actually go into the root of the meniscotibial ligament. And then we see these all the time. Peripheral tear of the posterior horn, which I showed you. Meniscocapsular separation. And that's what this is. And fat sac can really help you see that. It's usually filled with fluid and has a contusion under it. And then they have this other one. I don't see this too often, a double tear of the posterior horn of the medial meniscus. So I love the classification. It helps me know what to look for. So here's an ACL tear, and we're going to see something else now. And as we go from the notch laterally, we see our meniscofemoral ligament attaching to the posterior horn of the lateral meniscus. And that we should see that you can get a pseudo tear from that. But should it keep going? No. This is many cuts in going peripherally. Too much, there's a tear there.